Okay. Can you hear me now?
Yes, ma'am, perfectly fine.
Okay. Well, it's a pleasure to be here with you today. And I'm talking here from Houston, Texas, from our Retinoblastoma Center of Houston. I have no financial conflicts of interest to report. So the outline of this talk is mainly based of what Santosh Hanwar asked me to talk about. And it's just how the pathology and the clinician communication is very important to have a successful evaluation of the enucleated eyes. How unsuspected retinoblastoma sometimes is very important, the role of the cytopathologist to put the diagnosis in place. And our findings associated with higher risk for CNS recurrence came from the results that came from the COG study. So first of all, in the first question about clinician and pathologist, I think it's very important to have a interdisciplinary group to work with these patients, because all of we have heard throughout these talks the importance of all these different groups to have a successful treatment for the patient. So here in our group, what we do is to discuss all of these patients pre-treatment and also for follow-up. So for the clinical point of view, since we are in these meetings, we will know exactly the clinical presentation. Is this a typical presentation, an atypical presentation, primary versus secondary enucleation? So what I should look for when the patients are already treated, is this unilateral, bilateral? Exactly what are the concerns? Where is the tumor recurrent? How many chemotherapy rounds this patient has had? And if there's any questions in the MRI about the optic nerve, where exactly to look for. So this is really helpful for the pathologist. So I'll put an example here. Our great ocular oncologist, Dr. Gombos, sees the patient and diagnoses this 12-month-old with that presented with leukocoria with a group E unilateral. So after discussion, and especially with the parents, with all the options, the decision was to do an enucleation. So I already saw this picture in the tumor board, and then at the time of the enucleation, I get the fresh tumor. Ideally, the first thing to do is to take the optic nerve margin so that you are sure you are not contaminating this. Now, optional, and that's what I do in our group, is immediately after cutting, I do a touch imprint of the margin that I just cut off. And then you can see here that is blood, the meningothelial cells, and no tumor. This is confirmed by the final histologic section. We also aspirate aqueous humor from the anterior chamber, because we are undergoing these molecular studies, as we have published with Dr. Berry. And then we transilluminate. So we know exactly where to cut. And as we have published with the group of the International Retinoblastoma Staging Group, the guidelines for how to examine and manage these eyes, we do it under the microscope to select the viable tumor. So that's the one that we are going to harvest for genetics or treatment, research. Then we obviously confirm this is retinoblastoma by the cytology, and that the tumor that we are submitting for studies is viable. After the fixation, we obtain the central PO section, which is the central part of the eye, and the two calottes, never transecting the optic nerve. And then from the calottes, we do this Brett Loffin, and in 4 cassettes, you get all these, the entire eye. Very important, and this part is the one that sometimes people don't do, is to do serial sections through the PO section so that you actually see the center of the optic nerve, so you have all these structures in here. So what are we looking for in histopathology? The higher risks for metastasis or recurrence is the extraocular extension, of course, then optic nerve invasion, post-lamina cremosa, and more than 3 millimeters of choroidal invasion. In this patient, we had a very well localized tumor into the retina and intraocular, just subretinal RPE invasion. This is not choroidal invasion, peripapillary retina invasion, but not into the optic nerve. So this patient in our final diagnosis. So one of the things that the pathologist should do is confirm diagnosis. Okay, this is retinoblastoma, because sometimes it's not. And then in the next point, the important thing to do is to have the choroidal invasion of the optic nerve invasion, so that we can do the pathology part of the HACC staging. In this case, this patient has PT1, which is not invasive into the outside of the eye. The final stage is 1. And of course, we now include the H part, which is the hereditary. In this case, it was 0 because the study came back negative. And then in the interdisciplinary approach, we also counsel the patients genetically following these guidelines. Okay, so sometimes there are patients that have very atypical presentations. I'll quickly show you this one. I got a phone call from not a ophthalmologist, a hematopathologist working on a flow cytometry to rule out lymphoma. And she tells me, this is not lymphoma. I see a lot of cells. Can you please look at this? So this is outside in another state. So she sends the slide, only one slide. I see this. I see there's groups of large cells, calcification. So what do I know we need to do? I need to confirm what I'm thinking, which is retinoblastoma. Of course, we are talking about this, and I do the synaptophysin in the same slide. And this is just another case of retinoblastoma. More history. This is a 6-year-old female with retinal detachment that they thought it was Coats disease. And they went on and did a retinal drainage with 4 sclerotomies. And when they were doing the inferior one, they see this thick material. The surgeon thought it's lymphoma. And then he sent the vitreous. So of course, our final diagnosis in this case is retinoblastoma. Then this patient was sent for final treatment to our institution, negative workup for metastasis. So it was enucleated. We ink at the type of the surgery, the areas of the sclerotomy. And of course, this is a typical exophatic retinoblastoma, which is the most common one that is unrecognized and misdiagnosed as Coats disease. You can see the retina and the vessels will show up on the top, and the tumor is under the retina. So now here we confirm the same thing. Here is the retina histology under the retina. And in this case, the optic nerve is free. In the areas of the sclerotomy, the tumor is contained to the eye, no tumor in the sclera. And this is what you see in the real Coats disease. You see how the retina is pushed, and all of this can make a mass white looking because of the macrophages. And so this problem is always with a cytology interpretation when you have atypical cases, unsuspected. Now, in cytology, for us, these features are really different, although some people have trouble identifying this because they are not used to see retinoblastoma. As you know, you never, as ophthalmologist, if you know this is retinoblastoma, you are not going to biopsy. So the cytologists, they don't have experience with this. Retinoblastoma has this appearance of the rosette. Is in children. Medullopithelioma is also in children. Leukemia is in children. But lymphoma, as you know, many times more often in adults. Immunohistochemistry can help. You can do also the RB mutation staining, which will be negative because it is not present there. So usually these cases are the ones that present with cellulitis, anterior diffuse retinoblastoma, or Coats disease. And there are many published papers by many people here in the call that talk about the treatment after that. Now, to end my participation, we are going to talk about our findings in the prospective trial of more than 300 patients with unilateral retinoblastoma and histopathology. So why we are looking at this? Dr. Abramson made a very good point in his talk. You are not curing these patients by taking the eye that has choroidal retinoblastoma invasion or postlaminar optic nerve invasion. What you are doing is, of course, stopping the tumor to grow, but also at the time of our interpretation is predicting which patients may be a higher risk of CNS involvement or choroidal involvement. So for choroidal involvement, the thing that you will see, of course, the problem is not the choroid itself, is when it comes out of the choroid, and the vasculature that is going to drain is into the systemic circulation and the bone marrow mets. So these are more manageable, as we have heard and we will hear. But the problem is the optic nerve. The optic nerve goes into the brain directly or by the meninges and then recur. In this trial, what we found is that the combination of peripapillary optic nerve invasion, choroidal massive, and plony is worse. And just talking a little bit about post-treatment effect, you are not disappearing these risk factors at all. They were there. So even if you treat with the intraarterial, with chemo, whatever, you are already treating. You should be treating beyond what a localized tumor is. Because this is already out, as Dr. Abramson pointed out, you are just identifying the risk, but it was already there. So the problem with these patients that have been treated for the pathologists is that this thing is mimicked disguised by the treatment effect. So here you have this regressed tumor by the macula. It appeared that it was almost consolidated, but okay, they couldn't see the optic nerve. You see the optic nerve here. It's full of tumor. Actually, the papillary area was negative. So there was no tumor in the inner part of the optic nerve. There was meningeal invasion. This patient recurred and died of disease in spite of all treatments. So our hypothesis is when you have this combination of this massive choroidal and plony, you have the tumor coming from the choroid through the perivascular areas in both ways into the meninges. And even if you clear your tumor any way you want by surgery or by chemotherapy, the tumor is already in the brain. So in this conclusions of this trial is that the minimal choroidal invasion and minimal optic nerve invasion does not really need adjuvant chemotherapy. However, this combination most likely needs more intense adjuvant chemotherapy, as is where you were treating actually the metastasis that may already happen. And so, you know, with this stricter criteria, maybe you can have better prognosis of these patients. And finally, you know, this is a work of everyone together here in the Retinoblastoma Center of Houston. We work with all these people, and that's what we try to do, to have a multidisciplinary approach. Thank you very much for your attention.
Thank you.